So when does one start administering norepinephrine in a case of septic shock? To answer this question, I must begin by saying that there is no conflict of interest for me, and I'm going to try to begin right from the outset to convince you that we must begin a very early administration of NE in the case of septic shock, and this probably for 6 main reasons. The first of these reasons is that norepinephrine is the only treatment that is able to restore the blood pressure quickly. And I think that that is very important, particularly if you take into account studies such as this one that shows you that arterial hypertension is something that can actually be a predictive factor for the outcome of any septic shock. In this particular test, you can see on the gray here, on the curve, you have the duration and the depth, the time and the intensity of the hypotension. And the time and the intensity of hypotension, therefore, was a good independent prediction of mortality, independent from other factors for mortality and independent of septic shock. So arterial hypertension is something that would indicate that if you were to delay restoring the mean arterial pressure, then that could be very unfortunate for the patient. In this study that was carried out in 2008, this is a retrospective study, an observational study. On the 3rd day here, arterial pressure, not systolic but diastolic, and that has to do with the vasomotor tone, the arterial tone. So what would be better than norepinephrine to actually restore the diastolic arterial pressure, since it is related directly to the arterial tone? So it appears that when arterial pressure is very low, when you have very severe arterial hypotension, the treatment that appears to be the most logical and certainly the most urgent to administer is norepinephrine, so that you can decrease the amount of time spent in hypotension, you can decrease the intensity of the arterial hypotension, and thus indirectly improve mortality, and particularly when the DAP, which is a reflection of the arterial tone, is very low. This is to be found in the recommendations here. Using a vasopressor as early as an emergency measure in patients with severe shock is frequently necessary, as when the diastolic blood pressure is too low. So once again, I think that the first reason for which we should begin norepinephrine early in cases of a septic shock is that it is the only treatment, as I said, that is able to restore the blood pressure quickly. You could compare that to the duration that you would need for volume expansion and the time it would take to actually restore arterial pressure. If we were to construct a very simple algorithm for administering norepinephrine during septic shock, first of all, we have to take a look to see whether the hypotension is very serious, very severe, and therefore it's life-threatening. In that case, international recommendations are to start NE very promptly, that is, along with hydraulic expansion, along with fluids. If, however, it's in the case of less life-threatening hypotension, then the recommendations are also less clear. So how can we answer this question? How is it possible to decide whether to administer NE or not? I think in order to do this, you have to go back to the physiopathological effects of norepinephrine. Let's go back and take a look at the hemodynamic effects. The physiopathology is very simple. Normally speaking, norepinephrine is used as in order to increase the arterial tone. The first reason for giving NE is to restore the arterial tone. But it is also obvious, and we must not forget, that norepinephrine also works as a vasoconstrictor on the venous sites. It is also going to increase the venous tone. And this is particularly significant if there is high vasodilatation, particularly in cases of septic shock. And also, very simply, the veins also have certain alpha receptors that are targeted by NE. So if you administer NE, this will give rise to a constriction of the veins, and this venous constriction is going to promote or stimulate the venous return to the heart, and therefore norepinephrine should increase arterial pressure, cardiac pressure, sorry. So when you're wondering as to when to administer norepinephrine, that's important to remember. If it's going to improve the cardiac preload, then it should be administered. In theory, it should increase the cardiac preload. There are some studies today that show very clearly that during septic shock, norepinephrine does improve the cardiac preload. In this particular study that was published by Olfan Zawi in 2010, the population here was a large number of patients in intensive care suffering from a septic shock, and the increase in NE was observed here. You can note that norepinephrine increased the mean arterial pressure. It improved the arterial venous tone, but it also increased the overall of the global diastolic volume, which is at the very heart of cardiac preload. So not only does norepinephrine increase arterial vasomotor, but it also increases the preload, cardiac preload. This is something that we also found in these patients, septic shock patients, with an increase of norepinephrine. This was something that study that we did with Jean-Louis Deboul. We measured the transpulmonar. We measured this using transpulmonar measurements, and we saw that the volume expansion increased with the CVP, with also changes in the left ventricular end diastolic area, and that norepinephrine increased cardiac preload quite significantly. And what you can see here in this diagram is that norepinephrine also has an impact on the preload that is perhaps a little less, but it is still going in the same direction as volume expansion. And you can therefore understand the synergy that norepinephrine has with volume expansion in this particular situation. So it increases cardiac preload, but how does it do that? What are the mechanisms that underlie this preloading characteristic of norepinephrine? In order to answer this, we have to go back to the physiopathology of the pathophysiology of the systemic venous return during acute circulatory failure. This was described by Perischini in 2014. The systemic venous return looks like this. The mean systemic pressure is in the deep part of the heart, and it is then sent to the atrium. And the return, that is the blood flow, is going to depend on the pressure slope. And that is the relationship that you can see here. When pressure in the right atrial increases, the right atrium increases, the venous return decreases. And when you have a zero venous return, it means that the gradient slope is null and void. The right atrial pressure equals the mean systemic pressure, which is the intersection of the abscissa with the venous return curve. That is the mean systemic pressure. which in turn is going to allow us to describe the following. The two determinants for venous return are the mean systemic pressure, represented on this curve by the intersection of the abscissa and the curve, and the resistance to venous return that is shown on the curve by the opposite of the slope of the relation. So that is the determinant for systemic venous return. The question now is, what should be the impact of norepinephrine on that venous return? One would understand that in theory norepinephrine could have two different effects. On the one hand, because it's going to contract the venous reservoir, the norepinephrine could increase the arterial pressure, could pressurize the systemic venous reservoir, and that would increase the average systemic pressure and would logically mean that there would be an increase in the venous return to the heart. But on the other hand, you might think that the norepinephrine will constrict the vein, thus prevent the venous return back to the heart, which would in turn increase resistance to the venous return, which would give rise to a decrease in the systemic venous return. So there are different factors that could lead to completely opposite conclusions. What actually occurs in practice? There are certain studies that have focused on this issue, and these studies allow us to answer the question. This is one of the studies that we did with Jean-Louis Demoule and Romain. We included patients suffering from septic shock, in which the dose of norepinephrine was decreased. And with these patients, we used a method that enabled us to estimate the venous return curve, whereas normally you have to look at the arterial pressure during a patient suffering from cardiac arrest, which is not possible. So we used a technique that was described by a Dutch team, Janssen's team, which used the interaction of the heart and the lungs. So to sum things up, in one patient, we are going to induce certain pauses. There will be an end inspiratory hold and an end expiratory hold, thanks to the use of a ventilator. And you'll measure the cardiac output on the one hand and the right atrial pressure on the other. So during the inspiration, there is an increase of the CVP and a decrease in the stroke volume. And then afterwards, when you do an end expiratory hold, we drop the CVP drops and the stroke volume increases. None of this is very surprising. But the idea now is to take these couples that we've been able to measure when we were actually placing the ventilator and to put them on a graph with the cardiac output. So you have the CI on the abscissa, and on the bottom you have the CVP. This is an example that we have with one of the patients. These are all the points that we found. You draw your regression curve, and logically here you can estimate where the two will cross, and that's the value of the average systemic pressure. And because of the slope of the curve, you can also estimate the resistant venous return. So this is an approach that enables us to actually estimate the impact of norepinephrine during a septic shock. And we could do that before and after the increase in norepinephrine, as with this patient. The result of this study you can see on this single slide. In these patients, when we actually dropped the dose of norepinephrine, this gave rise to a drop in the mean systemic pressure. And at the same time, we observed that when you decreased the dose of norepinephrine, there was also a decrease in the venous return resistance. We observed, therefore, that the drop in the venous return curve was less than the drop of the mean systemic pressure. So if you use opposite reasoning, one can then suppose that if you have a patient suffering from septic shock and you increase the dose of norepinephrine, you increase the average systemic pressure, you increase the resistance to venous return, but to a lesser degree, which implies that in fine, norepinephrine gives rise to an increase in the venous return, an increase in mean systemic pressure, and therefore also an increase in the cardiac preload. These results have been confirmed with a method that is somewhat similar, confirmed by the team that I mentioned earlier. And you can see on this slide that the increase in norepinephrine gave rise to an increase in the systemic arterial pressure and an increase in the venous return, but to a lesser extent. These effects have been properly determined. So norepinephrine increases the mean systemic pressure and to a lesser extent increases the venous resistance, which results in the end, in the long run, to an increase in venous return. So once we have determined that, we come back to another issue. What are the consequences in terms of volume status? In the study that I quoted earlier, in this particular patient, we were increasing the dose of norepinephrine. We doubled it. Before having doubled the norepinephrine dose, so we did one of the passive leg raising tests, and you can note that these patients were all selected because they had a positive passive leg raising test. And because these patients, therefore, were preload dependent, you can see that norepinephrine had exactly the same effect. This is going to reveal an effect of norepinephrine that people didn't think of before. In patients that are preload dependent, norepinephrine increases the cardiac output as volume expansion does. So in passing, it also means that norepinephrine should decrease the preload dependency. One could imagine that in a patient that is in the initial part of the Frank-Sterling's curve for the preload dependence, when you increase norepinephrine, you increase the cardiac output, and a patient who was preload dependent becomes preload independent when you increase the dose of norepinephrine. So that's another impact of norepinephrine that has nothing to do with the simple arterial effect that we tend to be used to. In this study, take a look at the results of the passive leg raising test on the cardiac output. It decreases when you decrease the norepinephrine. All of these patients who were preloaded to start with have their dependency decreased. This again implies that norepinephrine, the administration of norepinephrine does the same as volume expansion. Another thing that seems self-evident is that when you administer norepinephrine, you also decrease the systemic venous volume, which means that you are decreasing the volume in which the volume expansion was to be found. And one can understand that if you increase the norepinephrine, you're going to have a vascular expansion that is going to be more efficient. So to sum things up, norepinephrine will have a significant impact on the venous return, on the cardiac preload. It decreases the venous reservoir in which that expansion will occur, and therefore norepinephrine should reduce the total amount of fluid that is required for patients suffering from septic shock. Here we can see that the the cumulative fluid balance, which normally predicts mortality in septic shocks independently. And in this cohort, this positive fluid balance predicted mortality in an independent manner. So norepinephrine does contribute to reducing the total volume of fluid administered and also to reduce fluid balance. So what have we seen up until now? There is some scientific evidence for starting norepinephrine early. Here is an endotoxinic shock model. This was done by Bruno Levy. The patients were actually rats in this case, and they were control rats, or they were being treated with norepinephrine or treated with volume expansion, fluid, and so forth. And you see that the administration of fluid and norepinephrine improved the mesenteric flow. It was better using both of them than just the fluids. And for oxygenation, there is also an improvement in tissue oxygenation. If you administer fluids and NE at the same time, this improved the hepatic oxygenation. One clinical study, and this is the only one that I'm going to show you, it is a Chinese retrospective analysis in 213 septic shock patients, shows that mortality increased along with the delay of norepinephrine administration. Mortality was higher in patients that received norepinephrine later, if it was delayed. Beyond 6 hours, their mortality was far higher than had they received norepinephrine in the first hour. Early administration of norepinephrine allows for a decrease of blood pressure in spite of a similar mean arterial pressure at baseline. And lastly, if we look at a multivariate logistic regression analysis of the independent risk factors for 28-day mortality, the time before administering NE allows you to predict survival in a manner that is independent from other severity factors. And this would suggest that early administration of norepinephrine should have a beneficial effect on the mortality of patients from septic shock. This suggests that even in the patients that have hypertension that is not life-threatening, one should still be doing an early administration of norepinephrine, earlier than what we tend to do today. Now, the argument that has often contradicted this has to do with microcirculation. Yes, but norepinephrine has a very dangerous microcirculatory effect. Clinical studies don't show that. Some of the studies have focused on microcirculatory aspects, but in this study done by Arnold Dublin, for septic shock patients, they studied the characteristics of the microcirculatory blood flow, and with an increase of MAP, there was an impact that was not clearly detrimental on microcirculation. This is another example, but in this study that was done by Jean-Louis Vincent, the microcirculation that was studied with the anatomical SDF system and also the functional system did not show any deterioration when there was an increase in norepinephrine. On the contrary, there was an improvement in the microvascular density. So the potentially deleterious effect of norepinephrine on microcirculation is not obvious as to date in published clinical studies. And I think that these are the 6 arguments that should encourage us to administer norepinephrine as early as possible in septic shock patients. Thank you for your attention. So when does one start administering norepinephrine?